Good afternoon and welcome. Welcome to Pressure Points, Engineering AI for the Future of Healthcare, presented jointly by the Harvard T.H Studio and Advanced Learning Academy. I'm Rifat Atun, Vice Dean for Non-Degree Education and Innovation here at the Harvard T.H and moderator of today's discussion. AI has already changed healthcare with machine learning tools for automation, generative AI for synthesis, and AI-assisted development. And today, we're focused on a newer shift, AI as a way to build. Now, agentic AI and vibe coding are making it possible for clinicians, public health leaders, and researchers to generate prototypes, create agentic workflows, and build internal tools faster than ever before. It gives us enormous opportunity, but with that comes obvious challenges. So our core question today is, what kind of healthcare organizations do we need to become when using AI to build? I'm delighted to be joined by our distinguished panel of experts. We have Trishan Panch, the CEO of Lunar Studio and Executive Chair and Chief Strategy Officer of Lumen Health. Trishan is also co-director of ALA's Responsible AI for Healthcare Innovation and our new course, Beyond Vibe Coding, Building AI Solutions to Transform Healthcare courses. Then we have John Brownstein, a distinguished professor of epidemiology and an innovator. He is Senior Vice President and Chief Innovation Officer at Boston Children's Hospital. Then we have Aman Bhandari, who is Chief AI and Analytics Officer at Scant Group, and Heather Matty, who is a lecturer in biostatistics at Harvard Chan School and co-director of ALA's Responsible AI for Healthcare and Innovation with AI in Healthcare courses. So let me start with Trishan. Trishan, help us understand the recent evolution of AI. And you've been operating at the frontier as a practitioner, but also as a thinker. How do you see the transition from vibe coding to agentic engineering? What does it mean for healthcare?
Sure. Thank you, Rifat. Thank you for having me. And it's great to be part of this group. I've learned a lot, and I'm continuing to learn a lot from Heather and John, Aman, and yourself. And I think the beauty of this field is that the capability is so general and it's so fast moving that no one really knows everything, right? And we're all just trying to figure out not just our piece of it, but how all the pieces fit together in for healthcare, very complex organizations with a just very high bar to pass. Like the reliability really matters and the safety really matters. So this kind of set of AI tools, there's I think everyone watching this, all of us in the on the panel as well, will have used the consumer AI tools, ChatGPT, Gemini, Claude, and most people will have seen these as kind of like essentially like a chatbot. You ask a question, it gives you an answer, and as distinct from, say, Google search, where you're asking a question and it's retrieving a web page and giving you an answer, or a social network or something like that. This is kind of an answer that's made bespoke for you. So that's like a new capability, the so-called generative AI, to be able to like produce something using AI. And there's a lot of things behind it, but if we just kind of package that up and that's the paradigm we're in. I think the thing that less people will be involved in, but we on the panel have seen collectively as a really, really significant capability, is the ability of those tools, those generative AI tools, not just to write English or French or German or Tamil language I speak, or any other language based on your input, but to write computer code. And often, but under the hood, behind the scenes, a lot of the things that it's doing for you, the AI is using its ability to write computer code to solve problems. And that's really what computer code is. Code is basically just like a way of solving logical problems in a repeatable and reliable way, right? So in AI, as in medicine, a lot of the terms that seem opaque are actually, in medicine, it's like a lot of the things are actually just exactly the thing it's describing, but in Latin. So it seems like kind of difficult to understand, but it's actually fairly literal. And it's the same here. So like, in response to the question you asked, vibe coding is the vibe is basically rather than the specific syntax of code itself, the exact language and punctuation, all that stuff really matters to take your intent as someone who wants code written to the output of that code to solve the problem that you had intended to solve. Now there is this capability using AI that the AI, just like when you type something into ChatGPT, it can understand what you want, what you're trying to request and say. And sometimes with incredibly imperfect descriptions, it kind of somehow figures it out. And there's some like good technical reasons why this set of technology is really good at doing that. So that same capability is applied to writing code is this thing called vibe coding. So rather than specifying the exact syntax and sometimes even the exact logic, you don't need to do that. You just need to basically capture the vibes, the intent, the kind of thing you're wanting to achieve, and the AI figures the rest of it out. Now that sounds kind of somewhat trivial, but professional engineers, and Heather's going to talk much more about this, including masters and PhD students here at Harvard who are training these things, are often using these tools almost exclusively because they've just got so good. Like the writing code at like a professional level is now something that computers can do, like reliably and largely safely, but not exclusively so. And so therefore we're now in this era. And so agentic engineering is the kind of just the practice of using agents. An agent is simply something that can pursue some steps to reach a goal. Like we're all agents here, I suppose, biological agents. AI agents are basically AIs that can do a multi-step process. So rather than you ask it to do something, it returns a result. You give it a goal of something you want it to do, and it can figure out the steps to reach that goal and then go and achieve that goal. So agentic engineering, there's another term that John and I are actually in the process of writing a paper we'd call natural language programming, which maybe is, a better descriptive term, is basically programming in natural language, whatever language it is that you speak. The most common one for AI, at least at the moment, is English. But it's basically like using AI agents in order to do software engineering. That's agentic engineering. And because of this capability of AI to write code at professional level for anyone, it means that and this is why this is such a kind of timely discussion, in my opinion, that many more people can now come into the fold of those that can create software.
So,
And,
yeah. So
please
this
go.
is a major transition.
Yeah,
If this changes who can build, this
yeah,
used to be the purview of engineers, computer
Mhm.
scientists, data scientists, and quants, as we call them.
yeah,
But if this changes who can build, then we need to ask where this capability will show up
yeah.
and show up first. So, John,
Mhm.
let me come to you. You are seeing this inside your organization, a
Mhm.
major and leading pediatric health system, Boston Children's. Can you give us concrete examples of
Yeah.
where AI-enabled building changes what a hospital can do?
Yeah, well, absolutely. And thank you. It's great to be with everyone here. I've had a first row seat into the transformation around AI at our institution for over a decade now. And it's really amazing to see the shift. We've obviously, AI is not new. We've been working on AI tools for many, many years. The journey has changed, obviously, with availability of tools, but also who's gets to build and deploy those tools, as Trisha was saying, is changing. So early on, of course, we relied a lot on our foundation partners, companies like Epic or Workday, or companies that were plugging into the EHR, ambient listing, for instance, which is highly deployed across healthcare systems. But the rise of these new tools means that as a chief innovation officer, as much as we love to work with companies and startups and our big partners in tech, the tools that some of these AI companies are making available does change the game. We really were trying to get away from a world of internal development unless it was critical, because the engineering resources at startups was just so far greater than what we could provide. But now, when a single clinician or one program manager or even a software developer can 10 or 100x their capabilities, it changes the equation around build versus buy. And so now we're doing a lot more building. And, the building could be for full, transformational enterprise level tools, or it could be building just a prototype and idea to understand if it's worth investing in potentially a new company or a startup in the space. There are many concrete examples. Recently, we've announced partnership with OpenAI in the world of rare disease, where we are transforming the diagnostic odyssey, bringing in genomic information, genetic information, and the interpretation of AI, especially across the massive world of literature, to make supportive decisions around diagnostics for families and kids that have been on diagnostic odysseys for years, if not decades. And what we identified is that through working with these foundation models, we're actually able to identify diagnoses and deliver new diagnoses to families that was once thought to be impossible. So it's really changing the game in terms of delivering care, but it's also changing our ability to support operations of the hospital. Where in one world we might firmly turn to Epic for the tools that they're building or other companies, our clinicians are actually vibe coding. One example is in our ICU, where there's such a demand for the integration of information across siloed information, and there's a need for pre-op notes or summarization of content across fields that some are, disparate sources of information. LLMs that sit across those various data sources can provide insight that was just not possible with the existing tool set. And these are tools that are being built by clinicians in partnerships with very small teams right now. And we're deploying these tools at the clinical interface. And so now our physicians have access to better summaries. They have access to better tools around coding. Another tool that we've just recently started prototyping is in partnership with Amazon, where we can actually build cohorts of patients. And this will be interesting to especially those in public health, the ability to walk through massive amounts of data across clinical data sets to build cohorts for research, for clinical decision making, to understand how to treat a particular patient against what has occurred with prior patients. These are all things that are in the heads of our clinicians, which there was a huge jump to get from an idea to actually a partnership in a company. Now it can take a matter of days or even hours to get a clinician co-developing or just building. And this is just the tip of the iceberg. We are seeing massive amounts of our physicians who are often trained in computer science as well, now having the capability to build where they didn't have the time to do that before.
This is really quite remarkable, given the short space it has taken to reach where we are compared to, say, 2 or 3 years ago.
Yeah, absolutely.
And this is happening at a specialist pediatric hospital. And I'm sure similar changes are taking in other sectors. So let me go to Aman, who's got very rich experience working in the life sciences as well as with health plans. Aman, where do you see the highest value use cases in life sciences and health plans? And how do you see constraints differing from those in a hospital, for example? Because these are highly regulated entities.
Yeah, that's a great question, and thank you for having me. I think John laid it out really well in that, first of all, this spectrum of opportunity has expanded dramatically, as you heard from the examples that John gave. And so there's an immense world of possibility. And I think that's simultaneously very exciting, but it's also can lead to sort of paralysis of where to get started. And so I like to think about, and John talked about this a little bit, is I love the sort of framework of thinking about, is this an operational type automation or use case or a problem you can tackle, or is this something that is clinical, or is it something that is going to be sort of in the clinical workflow, and dividing the world into those two things. And I think that there's now today immense opportunity on the operational layer of the day-to-day work, no matter what setting you're in. And before, that was very difficult to get to. It was also not something that was traditionally rewarded, was focusing on automating the operations of aspects of healthcare or life sciences. And now there's an immense focus that is now happening there that wasn't happening 5, 6, 7 years ago. And so one, I divide the world up into sort of operations, and then secondly, clinical, or something that's going to be touching the clinical workflow. The risk amongst those two things is quite different. And so you've got to have sort of a risk framework for, what level of risk are you taking? Is it directly in the care pathway? Is it something that's going to really dramatically impact patient care? And you've got to think about that quite deeply, quite carefully. And I know John's team are experts in this. And so that's one way in which this differs. On the operational side, there are immense things we can do. So to give you like one example about this. So most of healthcare, including life sciences, is overburdened by the amount of documents that one has to swim in or fill out or take through to go through from one part of the process to the end of the process. Think about just everything from clinical guidelines to filling out paperwork to thinking about the chart. There's documents everywhere. And with the advent of large language models, we can now like tackle using that text data that sits in many, many, many different types of documents across an entire enterprise. I'll give you one very quick example. So a problem that we tackled several years ago was looking at the informed consent form. That is the contract between the patient as well as a physician, as well as a pharmaceutical company. And so an informed consent form for a phase 2 or phase 3 clinical trial, you might have 1,000 different informed consent forms. That's like filling out a driver's license with the same information for 1,000 different, states or countries or whatever analogy you want to use. It's tedious, it's manual, it's the same information, it's time consuming, it takes months. And so the challenge we had was like, could you actually take something operational like that? And could you auto draft the first draft of an informed consent form and have a human review it and approve it at the end? And so that's something that we did. And so we were able to do that with high consistency, high accuracy, high validity, running, hundreds, if not thousands of simulations and tests to be able to do that. And now that's possible to do in any language, across any trial type, across any type of country. And so that's something that's very mundane and very boring, but it actually slows down the interface with the delivery system and trying to, in that case, bring medicines to patients. Yet it's a massively important thing to try to automate. And so I like to think about the operational opportunities, which are immense. And then there's some of the clinical opportunities, which are also immense. And John talked about some of those.
Yeah, I think these are really excellent examples. So there's a really very clear risk-benefit trade-off, and the tolerance for risk will be lower for operational, what you call mundane and maybe high-volume tasks that do not directly affect patient outcomes. But when it comes to patient outcomes, one has to have guardrails in place to ensure the risk is minimized. And some colleagues talk about zero error tolerance when it comes to patient care, because the therapeutic window, as we call it, is so narrow in some cases. So let me talk to Heather, who's done quite a lot of work on this issue. So natural language or natural language programming, as Trishan and John are calling it, makes systems easier to build. It's now a purview of many people, as opposed to a few very technical people. But it can also make assumptions harder to see. So what risks become harder to see when workflows are specified in natural language, especially those relating to clinical care?
Yeah, great. And also great to be here with everyone. It's interesting because natural language feels intuitive, but that's actually part of the problem. So when a clinician or operations leader specifies a workflow in plain English, they may not realize they're also encoding assumptions about which patients are included, which data fields matter, which outcomes they're optimizing for. Those assumptions are invisible in a way that a formal code specification is not. So really understanding what data you have access to, pulling that data in a particular way. In my own work on algorithmic bias and health disparities, this is where I see the greatest risk. It's not in the systems when they obviously go wrong, but in the systems that seem to be working fine until you stratify the results by sensitive attributes like insurance status, geography, race, etc. The bias isn't in the code. It's baked into the training data, the outcome variable, or the population that the prototype was implicitly built around. So if you can't read the code, they need to know the right questions to ask. What population does this perform well on? Where was it tested? What happens in subgroups? Those questions have to become sort of reflexes and not afterthoughts. And that's sort of where the risks become harder to see.
And then who should be looking for those risks? We know that it exists, but then what kind of system should one put in place, and who should be responsible or accountable, or even putting systems in place to mitigate?
That's a great question.
Heather gets the difficult questions because she's so capable.
Yeah, I try to think about where accountability lives a lot of the time. And so things that touch, in my opinion, things that touch clinical decision making, protected patient data or outcomes that vary systematically by patient characteristics, they need centralized governance, in my opinion, even if the building is happening locally. So the danger isn't that clinicians are building something, it's that they build it in isolation without access to validation infrastructure, fairness evaluation, or institutional accountability. And so one of the things I try to teach to students at the school, non-degree students, in my AI and data science courses, is that equity isn't a feature you add at the end, it's a design constraint from the beginning. And so if your team is building a care navigation tool and never asks which patients does this not work for, you don't discover the gap until it's already harming someone. So it's really, you need both the clinical and health expertise individuals at the table, you need the technical individuals at the table, and you need them to be communicating effectively with each other and sort of knowing which are the best questions to ask before we start designing and much before we start implementing anything.
Yeah, so leaders need to be really trained to really to understand the landscape, but also have new competencies. Leaders are involved in risk management and compliance, of course, but they need to understand this new language of validation, post-deployment monitoring, human-in-the-loop reviews and engagement, and be accountable for it. So I think that's a major transition and for institutions, because now more people can build. And the question is, of course, if more people can build, should healthcare organizations encourage that? So let 1,000 flowers bloom, or restrict it, because we are generally risk averse in healthcare institutions. So do we encourage that or restrict it to create a new kind of safe pathway or innovative approaches to creating workflows and pathways? So let's go to Trishan and Aman, because they're closely involved with this. What are your views? Let me start with Trishan first.
Okay, cool. Well, look, I mean, we've got a massive vested interest here, right? I mean, not only are we all building things ourselves, we're all managing other people who are being encouraged to build things using these tools. And then we are also teaching this class. So I think we're like, our kind of position just by that is probably clear. I think from my point of view, and certainly from the spirit behind our course, Rifat here, I think there's the I mean, it's said basically that like if we look at like one of the core elements of education, writing essays, and there's a lot of kind of things in the world that is there any point in writing essays anymore, because the AI tools can do it much better than humans can anyway, in pretty much any field. And yeah, you could have a nuanced discussion about, can it say something truly original, or is it just remixing stuff that's already known on the internet? And people have different biases in that area. But there is an argument there that like, what's the point of writing essays now that computers can do it better? And therefore, what would the point of handwriting code be if like computers can just do that much better than humans? And I would say if someone can write well, then they can think well, because there's something about structuring one's thinking, taking the universe of things that you could possibly say on a subject and boiling it down into like a coherent narrative and communicating that to someone else. Just basically, the process of doing that clarifies one's own thinking. And that really is what we're trying to teach in education. And I would say the same thing about coding. Like really what it is there's kind of complex logic problems in the world. There's information flows, and one is understanding how information flows and how information is transformed and engineered, and designing a better system to do so. Now, this new set of tools means you don't have to understand the exact syntax, like the equivalent of writing would be, the grammar doesn't necessarily matter, or spelling, because people, even if you're writing stuff yourself, have autocorrect. And now, like maybe the actual specific code that's being written can be written very well by a computer. Now, I would argue that you could still be better, even if you're using a computer, if you could write some of the code yourself. But it's really, honestly speaking, not necessary now. But I think the point is looking at a problem in the world and figuring out what the individual smaller parts of that problem are, and figuring out how it can be done better, and then building a new information system. I think everyone should learn to do that, and it's never been easier, because it will then spark one's curiosity to then look more at like the clinical system you're operating in, or like as a patient, like I'm having to like do these things to manage my own health conditions, or as a public health practitioner, I have all of these information flows of analyzing data and putting it in reports and communicating it here and checking that. And then your intrinsic creativity will come out. So I think it's very important that everyone gets involved, but I would answer it more almost from like an ideological point of view, because it's training people to think about the problems that they're facing and to have belief and, dare I say, agency that they can solve those problems themselves. And I think that's really important, especially in healthcare.
Yeah, and so this is the emphasis of the new course that we're launching in September. Enable many to build, because they're also closer to the pain points, and they'll be able to generate solutions that are locally specific. But obviously, one needs to have appropriate guardrails. So let's go to a practical example again. And John, having heard what Trishan has said, in a hospital, who needs to be at the table when things move from an idea to something that touches the workflows that you mentioned? Would it be IT, clinicians, data scientists, patients? What does it look like?
Well, obviously, I mean, it depends absolutely on what the project is involving. But the worst case scenario, and what I've seen fail many times, is clinician getting quite far along in building and prototyping, and then having to ask for forgiveness or for having to ask for favors to get something deployed. That works very poorly in our organization. The more you get alignment early on, which I know can be challenging, the better. We have AI governance already within the hospital that is made up of a diversity of participants that includes IT and includes clinicians, includes legal and finance and the wide and compliance, like the wide range of stakeholders. And we do have an effort to catalog all the AI efforts, prioritize them against enterprise needs, assess risk, determine whether projects can go forward, determine whether projects should get resourcing, understanding how projects may line up against other invested resources, because often what we're seeing is that the same thing happening over and over again, and IT is overburdened with requests, especially in this world. So making sure that we are breaking down those silos and gaining from the collaborations across different groups. We see it often where we'll see two different clinical departments working in very similar domains and trying to get those working, because unlocking data, security assessments on these tools, it is time consuming, and so we just don't have unlimited bandwidth. That being said, I mean, we have created pathways, we've created educational efforts and tools to understand what the guardrails are, so those clinicians can understand what they can and cannot do, and what tools they can use, what tools they can't use. And then our team in the innovation program can surround a clinician with support to help build and prototype and advance a project. And we're doing this on several fronts. So yes, like you need a diversity of stakeholders. That being said, we try very hard to take a different approach to what we call bottom-up innovation. We have top-down innovation, which is tools and efforts that align against the sort of enterprise goals, like documentation being one of them. And so, that is the set priority as an organization, and we put resources to work. One of the things that we try to avoid is just having enterprise priorities crowd out all the other innovation. And so we make sure that there's room for bottom up, where it's just coming from our researchers, coming from our clinicians, that they're feeling supported. Those ideas may not have enterprise-wide impact, but they can have significant impact significant ROI, significant cost savings, significant patient outcomes, significant provider and patient experience. So we leave room for that as long as it's sort of within the guardrails and visible to the stakeholders that we've put together.
Excellent. So diverse and inclusive groups,
Absolutely.
but also combination of bottom-up, so Trishan's approach of engaging more, but also top-down, combination of those, but within guardrails. And you mentioned sort of safe pathways. So let me go to Aman. Aman, what do these safe pathways look like in your world, or in the verticals that you work in, and what are the implications for leaders?
Yeah, this is a great question. So I echo everything that both Heather and Trishan and John have said about this. And the way that I think about it is, so when you look back at the data over the last 6, 7 years, maybe even as much as 10 years, all the surveys say the same thing, which is that 80% roughly of AI projects fail and 20% succeed. I think that number is going to stay about the same. And you want to be in the 20%. And so the question is like, what does it take to be in the 20%? I think John has described some of that. I think Heather's described some of that, like some of the capabilities that you need around bias and ethics. And so the 20% is really the outliers that you want to look at. And so the way that I think about it is, everybody wants their AI cake, but nobody wants the veggies. And the veggies include all those other things, right? Do you have a diverse team? Do you have, governance that is well represented? Do you have a balanced portfolio or a balanced meal, right, of things? Do you have somebody who's thinking about the ethics and the bias? Do you have validation and auditability? And do you have making sure you've got oversight and judgment that's involved? Those are all the veggies that you've got to have there. And if you don't have the balanced meal, you're not going to be in the 20%. And so one of the things I think a lot about as a shortcut of describing this to somebody who's far away from thinking about this is thinking about the scientific method. I'm a huge believer in following the scientific method for AI projects that you're doing. Why? Because a scientific method offers a structured process of experimentation where you've got to have a hypothesis, you've got to have a plan, you've got to have measurement, and you have an end, and then you can iterate. And so it gives you a way to describe to the organization to build that muscle of experimentation with guardrails. And we have human subjects review. We have the things that you think about in our world of healthcare and life sciences. People understand that to do it ethically, to do it properly, and to do it in a measured way. I think that's really immensely important. And so for leaders, I think they have a variety of challenges. One, having a structured and disciplined and methodical approach, having a balanced portfolio of AI projects that they're doing, right? Number two. Number three, collaboration is going to be far more important now in the future than it was before. We're going from a relay race. You can hand off your part of work to somebody else. Now you're in an orchestra. You've got to collaborate together, right? That's a different kind of game. So leaders have a lot of things to think about. The good thing is there are frameworks and there are success stories and there are organizations like Boston Children's that are highly successful and have been doing this for a long time that have put all the veggies in place. They have the balanced meal and they know how to do it. You can emulate that in your organization. And so there is a path forward to put those building blocks of success together, one piece at a time. You don't have to do it all together.
Yeah, no, that's really great to hear because some organizations have come up with sort of sandboxes to enable design, development, and deployment with the balanced access to data use, also product development, and then testing and introduction, and then clear rules for escalation when problems happen. But because everybody's building, so leaders need to develop a new sets of skills, but also build literacy. So let me go back to Heather with a hard question again. What does this build literacy mean for healthcare executive or public health leaders? Because it's a completely new set of skills and competences compared to a software engineer or a data scientist like you. And how should organizations create safe pathways for clinicians and operators to test ideas?
Yes, that is a big, tough question. Thank you.
That's the next part, I guess.
It doesn't mean we want the clinicians to learn to code. It means knowing enough to be a responsible steward of systems that you didn't build yourself or that you helped build or you built with AI. And I think it has three components. So first is, the problem specification. Can you clearly articulate what you're trying to solve for whom and what success looks like before you touch any tool? So coming up with the problem before manufacturing the solution. Second is evaluation. Do you know what questions to ask about a prototype's accuracy, safety, and fairness before you pilot it? And then third, which we touched on a little bit as well, is accountability. Do you understand who owns the system, who monitors it, what happens when it fails? I try to teach this, like I said before, a lot to the students, both on campus and off, and in sort of non-degree education context. So the goal isn't for us to produce clinician coders. It's to produce leaders who won't be fooled by a demo, who know the difference between a prototype that impresses and a system that's actually safe. So understanding really what questions to ask at the very start, who to bring in with different areas of expertise, having really open lines of communication the entire time. I loved that Aman talked about an orchestra. That's exactly what it is. And sort of being the conductor of that orchestra sometimes. And so I think in terms of how do organizations support that? I think time is going to be a big thing, as always. Having the time to do this, having the resources to learn about it, and then, the opportunity to maybe test a small pilot to get going.
Yeah, and you all mentioned sort of safety and guardrails being sort of critically important while allowing innovation and bottom-up approach with appropriate safeguards. So governance is going to be, or new modes of governance is going to be critical in the new environment that we are living in. So there's incredible potential for AI, but there are also risks. So how do we implement these guardrails and accountability when allowing many to build using natural language programming, for example, as you're saying, with AI? What are the minimum guardrails that need to be in place for AI-generated workflows to be tested in healthcare organization? And when do we say stop? And who says stop? So let me go to Aman first.
Yeah. Let me give you a practical example. So a lot of this has to do with a combination of what are the local laws in the area, the geographic area that you live in, right? So in the United States, there are different laws and regulations that are sometimes state by state. Overseas, the same thing. So one, you've got to be very attuned to what are the local regulations within your jurisdiction? That's first and foremost. And what does that apply to? Does it apply to privacy? Does that apply to security? Does it apply to where data lives possibly? So one, that it's like first and foremost. And so every place that I've ever worked or projects I've done with, the first person I call is the legal team. I'll make sure I'm very aligned, usually with a chief privacy officer, and say, we need to sit down together. You need to be at the table for all of the projects at the very beginning. So that's just a very practical thing. Who do you need to be aligned with like right away? In addition to the corporate IT team or other teams, right? Teams that are there that are control functions of the organization are control functions for AI as well, especially when you're doing enterprise scale stuff. So that's that's the first thing. I think the second thing, to give you a practical example, sometimes then you have to have your own judgment about how much further do you want to go. And I'll give you one example we had. So there's an example where we had personal data on people and we're trying to make a prediction of sorts. And we decided, even though it wasn't required by law or by regulation or by policy, we wanted to be extra careful. And what we said is, for every variable or feature we engineer within our data set, we are going to have the legal team approve every single variable, every single feature, one by one. On the one hand, it's very painstaking and painful. On the other hand, we decided to use our own judgment to say, there's no point in taking risk here. We want to be very conservative because it's not going to change the nature of the impact we can drive. Rather, we want to do this the right way because it was that important to us as an organization. That was just a judgment call. So to summarize, I would say it's a combination of being very attuned to the control functions of a large enterprise and the legal ones, the IT ones, security and privacy, and then also layering in your judgment as well. And then I think the third piece is what Heather outlined, which is right up front. You have to know, define your problem. Like, is this going to have the intended impact? What are the unintended impact? What is the unintended impact? That's the third layer in the design. And that's why I believe in the scientific method, the design of the experiment. And so you've got layers here of application to have the guardrails that are going to be in place. And there are many other layers of guardrails, but just to give a high level framework of at least how I think about it.
Excellent. And so a combination of, again, bottom up, but also with top down guardrails and frameworks and the scientific method. But always go to the
and one other thing else, one other thing I'd say here is literacy also applies to the technical experts. It's not just the everybody else, but I have a system in place where the technical experts who are building models or using AI, they themselves go through annual training on the latest privacy regulations, as well as ethical and bias training as well. So literacy applies to everybody. Just I'm not absolved of literacy myself, I guess is another way of saying it.
Okay. So we have many of these solutions being developed. So we have demonstrations, we have prototypes, but then someone needs to make a decision. How do we move from prototype or demo to full deployment? And one has to choose. So John, this is what you do. So what is the process for moving prototype to deployment?
Yeah, it's a really good question because it's very easy to vibe code a prototype. It's very different to have it deployed in the enterprise. But maybe that's okay. To Aman's point, maybe the objective is proof of concept to open up the organization's eyes to an investment in a particular area. And then, of course, you can either then build out a platform that is really compliant and secure and has all the guardrails in place. And that initial prototype is just meant as an example, not as the final end state. But you can definitely choose various paths. One is, of course, you have something that's vibe coded, and then we decide, it's better to work with an existing partner. I mean, there's many times where we can push Epic or another platform to build something because now we've showed the impact and value. That won't necessarily make our innovators happy if we're just like, great idea. Now, Epic, you can go and take that and buy it. But that often sometimes happens. And we can debate whether that's a good or a bad thing for the world. I'm sure there's various views. But we try to surround the clinician or vibe coder or whoever it is very early on. I think Aman also mentioned getting various stakeholders like legal and compliance, security in play. The biggest hurdle that we often have is the security review. And this is going to be even a bigger and bigger challenge as we move into this new world of vibe coding, especially with, even models that we don't even know. And marketing would suggest that models like Mythos and others are incredibly powerful. We'll have to see what is real here, but the power that will rest in the individual will continue to grow. And I guess, I don't know, is it Superman? I mean, Spider-Man, great power comes great responsibility. There will be a lot of responsibility placed on individuals to develop and code responsibly. And there's going to be a lot of pressure on a chief security officer to think about the risks of some of these platforms. I mean, so far, we're allowing for coding tools. We have Codex and Cloud Code in our environments. We do not yet have co-work, both because it's not HIPAA compliant, but also the worry of some deployment of these agents in our systems and not being clear of what might take place and what could be undone. We've seen examples in other industries where some real harm has been done by the deployment of these tools. So as much as I'm an innovator at the core and I want to build fast and develop and deploy, one bad move by someone who had the best of intentions could topple this entire effort. And so we are being very careful about what goes beyond just sort of a pilot example to something that's really deployed in our own environment.
Yes. Oh, excellent. This is a sort of perfect segue to my question to Heather. So we've developed build culture, build capability, build literacy. We have a scientific method. We've got the frameworks and the guardrails, but there's a huge risk of harm. So where's the red line? As we develop these capabilities and use agentic AI, what should never be delegated to an AI agent without meaningful oversight or human confirmation?
I get all of the
Because
tough
the risk of harm is so high, it seems from John's comments.
Yeah. I think, I mean, I would argue to always have a human in the loop at every step of the process and if not, running the code or analysis or something, to at least checking it, maybe not every single day or anything, but have regular checks and evaluations along the way. In the piloting process, having humans be able to flag something and say, hey, this is wrong, or this should be, something different. I guess I'm a very risk averse person personally, so I like to have as many humans in the loop as possible. But I would definitely not, we don't want to get rid of the clinicians, the healthcare workers. We just want to augment clinical decision making. We don't want to replace it with AI.
Great. So maybe very quickly, Trish, because you're a clinician and you're involved in developing these solutions. And Aman mentioned sort of the operational level solutions, but also then clinical solutions that affect patient care and patient outcomes. Where would you put the boundaries in terms of where human in the loop, as Heather is saying, should be clearly involved?
Yes, a very interesting question. So, I mean, I think the kind of safest way of looking at this is that there's the R&D has been done in all of the kind of administrative and operational areas. And really what we're trying to figure out now is the product surfaces, the business models, the governance and safety, right? And that's kind of what we've been discussing. I'd say on the clinical side, the R&D is still being done. And the good news is that what has been done is incredibly encouraging. And if you look at it from a public health lens or a health systems lens, Rifat, I would imagine there's maybe a different conclusion one comes to rather than looking at it as an individual clinician, or maybe as an individual patient. And I think there's very, very complex emotive issues that need to be figured out in terms of what does society or what do health systems want computers to do versus humans doing. Even if they are technically better, certainly at a population level, there will certainly be some failures. I mean, this is kind of classically described as the self-driving car problem. Even if on aggregate, like self-driving cars are safer, there are going to be some failures, potentially, or certainly what has been proven out, many less failures than human drivers. But how does society feel about those failures when they're when an AI or a machine is doing them versus and that machine might be owned by like a company or a large national health provider versus an individual doctor or an individual driver. And we haven't really figured that out. That's a broader debate with respect to AI. But on the R&D front, clinical reasoning, i.e. like not just answering questions in exams, but taking objective signs from, how a patient that can be derived on examination and blood tests and investigations, and then the subjective reality of that patient as told through history and very diffusely specified language to like a diagnosis, a management plan over time and getting that right have been proven in the last couple of years as like things that AI can do. And those things are being proven out at larger scale in, less abstract and more concrete real world clinical settings. But we're still nowhere near the where we are with these discussions that Aman and John are leading here about, well, the R&D is done and it basically works and the risk is acceptable. So let's figure out the products, the business models that kind of, align incentives between the different actors in the healthcare system and the governance and safety and training elements. Like that is still to come. I would hope that if we had this discussion in a year's time, that would be much more mature and we could point at specific examples. But the problem is that that's hugely iconoclastic for a number of powerful groups within the medical profession and amongst patient advocacy groups. And that is a whole other meeting.
Okay, so that's a perfect segue, Trishan. So as we transition into the future, and you've made a very compelling case for enabling and developing an ecosystem that enables building. So for healthcare leaders, in developing such an ecosystem, how do we enable building responsibly and moving from demonstration projects to full deployment in a way that is effective but also safe? So what kind of mindset should healthcare leaders develop? So 30 seconds. So I'll start with who'd like to go first? Maybe I'll start with Aman, then Heather, John, then Trishan. So 30 seconds each.
Yeah. So very quickly, we're undergoing a massive leadership test right now in the system. And so this is all of immense importance. What I'd say to leaders is now is a time where you've got to be the most optimistic person in the room and the most skeptical simultaneously. And you must chart a path forward because you will determine the success of your organization by charting that path forward.
Excellent. John.
Yeah, I mean, I think very similar to Aman. I mean, right now we are trying to make sure that every leader in our organization is upskilled and can vibe code and build with AI. Like it's not going to be happening at sort of at the grassroots level. It will, but every leader has to be trained and upskilled and using these tools in day to day to be actually a good leader. Many people think every CEO basically needs to be the chief AI officer of an organization at this point because they need to live and breathe this if we're going to see the transformation that is required. It cannot just happen among engineering or a sampling of AI sort of enthusiast clinicians. And so it has to be part of the fiber of every health system going forward.
Wow, that's quite remarkable. Heather.
I want to echo everything that Aman and John said as well. But just again, figuring out what you don't know, figuring out the questions that are really important to ask, not only for your product or tool or whatever to be successful and efficient, but also to be safe. And I think, being very comfortable with communicating with everyone on your team, everyone across the, different fields of expertise, asking a lot of questions. Nobody knows everything in general, but definitely not about AI. And so having a very collaborative and being optimistic, but also skeptical, as Aman said, I think it's going to be the way to go.
Excellent. And Trishan?
Cool. Yeah, I mean, excellent points. I think Rifat, from the Advanced Leadership Academy that you're leading and the many students that have come through that, I think we've kind of seen the answer to this. So I definitely agree with everything that's been said, but also I think it's important to be part of a community of people doing this. So I think Aman, John, Heather, myself, we are fortunate to be here and be surrounded by people doing this kind of work. I think, as Aman and John said, enlightened organizations will be replicating that where they are. But I think even if you are in one of those organizations, and especially if you're not, I think what we feel is very important is that not only to kind of get started and learn the spectrum of skills that are required, but also to be building things and doing so with other people who are informed, reflective practitioners. And I think from our point of view collectively here at HSPH, that's why we do the education the way we do it, that we do it through remote learning. Part of it is not just the information, but bringing people together around the information and getting them to collaborate and building stuff.
Okay, so a new mindset around collaboration, orchestration, as you called it, but creating a community and an ecosystem. I mean, this has been an incredibly rich discussion as I expected. Sort of a few sort of key messages. John, you start with sort of build versus buy. Clearly, we're in the phase of build, and then build locally, but with some central guardrails and approaches. And And Aman mentioned the scientific method, ensuring risk frameworks in the process. Opportunity is really great. Then we talked about ensuring solutions that are not just efficient and effective, but also equitable, ensure that there's no algorithmic bias, responsive to needs of different groups, but also safe, especially as we move from demonstrations to deployment. And one has to ensure that everyone's skilled in the process. And John, your statement was very powerful. Every CEO needs to be a chief AI officer at the same time. So we need to not just build capability, but also build literacy. So these are major transitions for organization. And I think this discussion is very timely. And thank you for this incredibly fascinating discussion. And those of you who have been watching this program, if you want to learn more about the topic AI and other leadership courses, you can find information about Harvard Chan Advanced Learning Academy in the YouTube chat. A recording of this program and the entire Pressure Point series are available on the Harvard Chan YouTube page. Thank you for joining us, and huge thanks to my outstanding panel, Trishan, Aman, John, and Heather, and huge thanks to the studio team.